In our panel discussion on this Monday, we reassess Korea's Omicron outbreak amid predictions of a peak this week to pave the path for a more contained situation as we look ahead to a warmer season of spring. For more, I have Professor Kim Moon-gyu from Yonsei University. Professor Kim, it's good to have you back here in the studio.
Great to be here again. Thank you.
I also have Professor David Kwok from Sooncheng University. Professor Kwok, welcome back.
Good afternoon.
Right, Professor Kim, health authorities here believe that the Omicron wave, or our Omicron wave, will come and go sometime this week. Do you share this outlook?
As I see the number of today, I was very happy. It was decreased, and actually, if we look at the 7-day average of Korean cases, we had a 2-month continuous rise, and now we have a little bit of ditch. I hope that there will be a peak, and then we can say that we're passing through the peak. But it's very hard to expect. Anyway, it's encouraging. Many European countries ease their measures, and they don't wear masks, and even they stop isolating people coming from other countries. As a result, some of them are showing resurgence, and is it because of this BA2 or stealth Omicron or not? We don't know yet. So I think 1 or 2 weeks more, we need to make a conclusion. And but even though we passed this peak, we have to be vigilant because we don't know whether a new variant might emerge, and we also have to care about the ICU situations.
Right, which remains above 1,000 for the 14 days straight, right?
Yeah.
Professor Kwok, starting on this Monday, as my colleague Yeon mentioned, the cap on social gatherings has been lifted to 8 people. Now, some experts believe this move itself may aggravate or perhaps delay our Omicron peak. What are your thoughts?
As Dr. Kim mentioned and explained, we might have overcome the peak. There's a possibility of that. And if that is so, I don't think the changes made in the social distancing guidelines will affect greatly of further transmissibility, because it'll probably mean that we've already gone through the highest transmissibility in the past week or so. But despite that, there is one clear study that was reported by CDC that compared different kinds of social distancing measures as to how effective it was in preventing and stopping the transmission of the virus itself. And they actually found complete isolation of a focal geographic area to be not as effective as expected. But only one thing that was effective was changing of curfews and times of bars and such venues that was run. So in that regard, I think changing from having people gather only from 6 people to 8 people will further enhance the possibility of people gathering more in such venues, so that it can also increase the transmissibility in the long run. But once again, as I said, if we were to have gone over the peak already, and I've actually saw that, as our reporter Kwon's already mentioned, we have dropped about 120,000 or so compared to the last week, and I think that's quite significant. And today, so far, we're seeing a very low number still accumulating within the day, and I'm having my fingers crossed that that'll stay that way. If that is so, I don't think this whole discussion about whether or not the social distancing guideline would further affect the transmission or containment of transmission will have any impact anyways. I think we should rather focus on, as Dr. Kim and you already also mentioned, that we really need to focus now on containing of the numbers being admitted to ICU units, and also blocking people from dying from COVID-19. And that can only be done by really focusing our all energy to the most vulnerable population, people with heavy underlying diseases and whatnot. So I think I just want to emphasize in this moment that we really need to be focusing more on protecting those who are more vulnerable.
Right, and talking about people who are more vulnerable, Professor Kim, there are calls for tougher restrictions at high-risk facilities, including nursing homes. What are your thoughts?
Yes, nursing homes and also hospitals caring about severe cases. I would say that if we had a barrier at the entrance point, like airport or seaport or something, now I think that barrier should be for those facilities caring for elderly patients with underlying conditions. But since we give up that epidemiologic investigation, we don't know where it's coming from, how is it coming from, and we have this huge number of patients. So we are living in a Omicron era, high transmissibility, even though it's low mortality. So if we want to lower the severe cases, we need more care about those facilities, more manpower, our nursing homes, and those facilities must do the PCR test before rapid antigen test because it's not that accurate. And we should include people caring for those elderly and family members also. So if one of your member works at those facilities, I recommend to try PCR even before you do the rapid antigen test.
Right, just to be safe.
Yeah.
Meanwhile, Professor Kwok, how might the growing number of stealth Omicron infections affect perhaps the course of our current outbreak?
Well, it's a tough call to make on that issue because different countries are currently showing different curves despite having about the same composition of BA2 composition, namely the stealth Omicron. It's named so because it cannot quite well be discerned as being an Omicron, but it mimics a fashion of Omicron in its composition of genomic codons. Currently, we're seeing in countries like the UK, France, and Germany to actually be resurging back up quite highly in their daily confirmation cases, and also currently having a increasing percentage of BA2 variant in their composition. But it's also the same in the US, except it keeps declining in their daily confirmation cases. So we cannot solely blame on the composition of the stealth Omicron to be manufacturing higher numbers of daily confirmation cases to actually bring the curve back up, because these different countries are showing different results despite having a huge portion of it. I think mainly in the European countries, the resurgence is quite possibly due to, once again, their drastic change of social distancing guidelines. They're set to currently be opening their borders up to like everyone who's coming into the country, whether or not they need quarantine measures. Such drastic measures would affect the domestic cases because there will be continuous inflow of daily confirmation cases anyways. On the contrary, I think the US, having had open borderlines already throughout these pandemic history, would not be so affected by the effective or the power of BA2. So in that regard, as we are growing in our own composition of BA2, unless something drastic happens in the social distancing guidelines or something that affects the transmissibility of the disease itself, I don't think we're going to see a huge, let's say, resurgence in the curve or a huge changes in the transmissibility for that matter, because we've sort of prematurely begun the changes in our social distancing already. And I don't think that is bound to change stepwise once again. I think it's going to stay rather more smooth in its progress. So I don't think the changes in the composition of BA2 is really going to affect our own curve in that matter.
Right, and I sincerely hope you're right, Professor Kwok.
Me too, actually.
Professor Kim, reinfections have been relatively common amid Omicron. Do tell us a bit about the criteria to classify a reinfection case.
It's very confusing because we have a name repositive and reinfection. First of all, let me explain about what is repositive is. You know, even though we recover from any COVID-19, you might still have positive results from PCR. And if it's within 90 days, and if the CT value is higher, you think it is really positive. This does not mean you are still infected with that virus. You may spread some virus particles out of your body, but it does not necessarily mean it is infection. CT value is something very confusing, but you can understand that if the value is low, you have a high virus loading. If CT value is high, over 35, that means the viral load is very low. You have a very low possibility to transfer the virus. So now let me explain about what is reinfection. If it's more than 90 days after the previous infection of COVID-19, and if the CT value is less than 35, we define it as a reinfection. And some people say that Omicron has a high reinfection rate, but it's a little bit tricky to say that. If you had a previous variant infection like a Delta or anything else, and then if you get Omicron, it's possible, but we don't have the data about having Omicron and getting Omicron one more time. So we don't have the data about that yet. So 90 days should pass and then we can have the data.
Right, I see. And in the meantime then, Professor Kwok, how do you explain this reality of rising reinfections in light of Omicron, and what are its implications?
Well, as Dr. Kim also said, it's possible that we would be getting Omicron infection, a super infection that was done to a person who was infected with other variants. Because we haven't had much time only with Omicron yet, those so-called cases of reinfection that we're currently talking about may well have been really infection breakthrough cases that was broken through by Omicron to a person who's had, let's say, Delta variant. Omicron, from the get-go, has already been studied to be able to very easily make breakthrough infections to people who's had COVID-19 or who were protected through, let's say, intentional immunization through vaccination, mainly because the major variant of its genetic codon that's comparable, well, that's differentiated from past variants, is on the attaching site. And we mainly focus on our immunization on the attaching site. We immunize ourselves, or we focus on immunizations against attaching site because we think that will protect us from being infected. Now, Omicron having these differently morphological attaching site compared to, let's say, other variants from before, it would more easily, comparatively to the prior infective sources, attach still, despite having a person be immunized, whether that be through natural immunization or vaccination. So, in theory, these reinfection cases, thinking about the possibility, it's more likely that these reinfection cases are actually due to a person having had prior variants, but now being infected with Omicron variant, than a person having to go through 2 times of Omicron variant infections. Because if a person was to have grown immunization against specifically Omicron variant, it's very much likely that that person would have immunization not just in the sense of antibodies, but other types of immunity specifically against Omicron variant. So that person would theoretically be much preventable to be infected by the Omicron variant.
Right, I see. And moving forward, Professor Kim, last week Israeli authorities reported a new strain that was a combination of Omicron and stealth Omicron. Could you tell us a bit more about this finding?
Well, it's something we can expect. It's kind of a subvariant that having both characteristics of Omicron and stealth Omicron. And it's not the only one. In USA and other countries, they found a new variant and named it Delta Cron, also meaning it having the characteristics of Omicron and Delta variant. It is too early to say we should worry about it or not, but the important thing is it doesn't matter how we find characteristics in molecular studies. The important thing is how our body responds to those new variants. So if our body reacts as same as Omicron, there's nothing to worry. It's nothing new, I mean. But there's no guarantee that there will be no virulent strains anymore. There's no guarantee about that. You know, after Omicron, we might have a highly contagious, highly mortality pie or something else. So we must control this pandemic before things get worse.
Right, and speaking about controlling the pandemic, Professor Kwa, Korea's Celltrion has secured a generic license to produce Pfizer's Paxlovid. How does this license perhaps look to affect Korea's own supplies of COVID-19 treatment pills?
Well, numerically speaking, I guess it would help, because being able to manufacture more doses for ourselves would obviously put ourselves in a better position to fight against this virus. But we're already seeing decline in the number, and we mainly have to focus with more vulnerable population. Paxlovid being used in the vulnerable population, but also at the same time very limited, because people who are more vulnerable tend to be also taking medications that are heavily metabolized through liver, which prohibits the use of Paxlovid. So I believe the government has made a statement today that they're going to import 100,000 doses of molnupiravir. In any sense, I think manufacturing more medicine that we can have in handy so that just in case numbers start to rise again, or we need the medication to fight against the virus, it'll be very helpful. But also in a sense that there's a certain limitation to Paxlovid specifically. I think we need to start thinking about more keeping the balance of different kinds of medication that we can use in the same group of people. I think we also need to start talking about whether or not we can possibly use corticosteroids in these vulnerable populations, because many doctors around the world, even though it was not formally studied yet, and currently CDC is not currently recommending highly on the use of corticosteroids, it seems like clinically people are finding out it is very effective in minimizing harsher symptoms of currently infected COVID-19 patients. So different kinds of a diversity of medication, whatever we can get our hands on, the more we can have them, I think we'll be ready.
Right, and speaking about diverse treatment options, Professor Kim, health authorities here are also looking to approve Merck's molnupiravir. What can you tell us about the merits of adding this particular antiviral pill to our treatment arsenal?
We have to compare with Paxlovid first, but I'm sorry that it's not that effective as Paxlovid. I mean, Paxlovid is known to have about 90% of effectiveness, but molnupiravir was originally said that only 30% of effectiveness. Paxlovid has a shortcoming, as Professor Kwak mentioned, many precautions. Some people cannot take it because they're already taking other kind of medications. But molnupiravir is relatively safer than Paxlovid. There was a recent article from British Medical Journal insisting that it's about 50% effectiveness, but it's only studied with unvaccinated people. So I think that's the reason they have a higher effectiveness. So if Paxlovid is not available, if we don't have it enough, I think there will be a role for molnupiravir. But there are two things we have to remember about molnupiravir. It causes a mutation in coronavirus. So if some fatal mutation happens, the virus will die. But same can happen. This kind of mutation can happen to mammalian cell in vitro. So if somebody is pregnant or should be cautious, we cannot use this drug. And as this drug is causing mutation, we have to take this medication just as prescribed. I mean, we have to keep the rules. Remember in 2009 we had a flu, and we had Tamiflu. Tamiflu was same. When we used a 5 days course, but it was strongly recommended to keep on 5 days. I mean, you might feel better and stop it with 2 days or 3 days, and that will end up a new variant of influenza virus. I think it should be applied same as molnupiravir. If you want to take it, you better keep it the 5 days course.
Right, so you have to be strictly adhering to the prescription.
Follow just as the prescription is ordered. Yeah.
All right, I see. Professor Kwak, medical practitioners who are at home with COVID-19 have been temporarily permitted to engage in telemedicine. This reality, I'm sure, shows us that there's a dire shortage of labor in the medical arena. And having said that, how effective is this particular practice of telemedicine?
I guess it'll be the best alternative to what we have in regards to human resources. I am visually seeing that there are departments even within our hospital, due to doctors and nurses being infected, they have to be out for a certain period of time. And without personnel, we're not going to be able to treat our own patients. There are certain type of patients doctors and nurses can still be able to help over the phone, such as making a prescription, because we can still consult them accordingly to their verbal consultative symptoms. So I think it'll be the best alternative, but this temporary measure, I think, will be taken out in a very brief period of time, because as we're going through this, the doctors and those medical personnel currently being infected will only be out for, let's say, a week or two. And if we go through it all together, let's say I'll give it about 3 to 4 weeks before everybody returns to their job and start actually treating patients on face-to-face. So this is temporary. I want to emphasize that this telemedicine is not something that should stay, but it is only a temporary best alternative measure. I think it would also work as the best alternative measure.
Right, at this particular moment in our fight against the pandemic. All right, Professor Kwak, thank you very much for your thoughts. Professor Kim, as always, thank you very much for your insights.
Thank you.